Hello everyone, welcome to a new episode of Retina Chats, and today we'll be discussing a pediatric retinal detachment case.
Hello, everyone.
First, I want to ask you, in pediatric retinal detachments, do you have any more concerns than adults? How do you counsel these patients? What do you tell them differently than adults?
Actually, it depends on the cause of the retinal detachment. Is it due to trauma? Is it due to genetic disease or a syndrome? So typically, it differs from one to other. If it is a traumatic one, so we have to say that we may need multiple interventions. I may add a buckle with the vitrectomy. Uh, if it is just a dialysis, I may put a buckle. So it's a long discussion and counseling for different types for retinal
So
detachments.
it's generally a more complicated case than regular
Sure.
ones, and you need to spend more time with the child or with the parents of the child to counsel them more than the regular cases. So I think that you have to take a pause in your clinic to just talk to them more and more about the expected complications. So this is it's a non-traumatic case. He's a high myopic child. He's 10 years old and presented to me with spontaneous retinal detachment. As you can see here, there's multiple tears and there's a large tear on the temporal side, almost a giant retinal tear. And we can notice here that the posterior hyaloid is attached. As I'm going with the cutter over the surface of the retina, the retina is moving, so there is a complete posterior hyaloid attachment. For you, in these cases, do you believe this could be a syndromatic case? It's a non-PVD detachment with multiple retinal tears, and
Yes,
no history of trauma. So,
yes, I believe it's a typical syndrome, whether it's a stickler or another one, but with this large GRT and multiple small tears and these pigmentations,
and the
definitely this
absence
is
of
not.
posterior hyaloid detachment. Yes.
This is an addition, but the multiplicity of the tears and some of them are radial, so probably are not due to a PVD or trauma or the regular cause of retinal detachments.
Yes, that was my thought process at the time, but unfortunately, we don't have the available genetic testing, and so we just have to assume it's a syndrome. Okay, so now I realize that the posterior hyaloid is attached, and I have to detach it. I tried with the cutter, I failed, so I stained with triamcinolone, and now I'm shifting to a forceps with the high mag lens to be able to detach the posterior hyaloid.
As you know, I'm not a fan of triamcinolone, but in this case is it's mandatory to
To
highlight every piece of the hyaloid, and especially in the posterior pole to remove all the hyaloid as you are showing us. So
okay,
this is a very good tip for this case.
yeah, okay. So in these cases, you generally use
Yes, in
triamcinolone
pediatric
more.
as well. Yes.
Okay, so and now I succeeded to detach the posterior hyaloid from the disc and macula and posterior pole, and now continuing to start and try to detach the hyaloid from the rest of the retina.
Wouldn't you eager to add some of PFCL?
I will in a moment, yes. But I try to just like finish as much as possible before injecting PFCL, then shift to PFCL as an additional.
Sometimes this PFCL bubble may propagate and may even dissect below the attachment of the hyaloid, and it may even detach the hyaloid from the retina in some cases.
Okay, so yes, this is a nice tip. Okay, so now I'm trying with the cutter under the PFCL bubble, but we can see that there's a very
Firm
tight, firm
attach. Yes.
attachment, especially at the pigmented area. So, any tips on or something you do more to detach these? Would you shift to bimanual? I've seen some surgeons use two forceps to just like
Opposing
yeah,
attraction,
opposing
yes.
forces to detach it from the retina. Do you like this kind of way to deal with this hyaloid?
Sometimes you may tend to use it, or you it's a must to use this kind of dissection, that you peel the membrane and you pull it in two different directions. So it is not the common way to detach the hyaloid, but if it's mandatory, as in this case, because you have, this is a very anterior attachment for the hyaloid and you cannot leave it as this area. So if you cannot propagate the wave and you remove at least the posterior pole hyaloid, yes, I may resort to bimanual and start to peel the membrane into different opposing
You can
directions.
notice here that while I'm pulling the posterior hyaloid, there was an iatrogenic tear. Would you stop and just leave the hyaloid in place, not to create more tears, or would you proceed to peel more and more, even if you're going to cause tears?
It
So this is
depends.
a question that was going through my mind at this step.
Actually, it depends on the area where you are going to leave the hyaloid. If it's a peripheral, posterior to the equator, it's okay, and you may add laser. But if it's almost at the arcade of the retina, so this is very very anterior to leave these all these hyaloid, especially that there is a large GRT still peripheral to the area where you are leaving all these gel. So probably this may add to the cause of recurrence later on.
Yes, that's exactly my thought process. I decided not to leave this hyaloid, and to try as much as possible to peel them and to remove them, as even if I'll cause iatrogenic tears. So here I'm pulling more and more force, but I realized that as time goes by, there is more hydration to the vitreous and things come
Easier.
easier.
Yes.
So what I want to say, that in these cases you have to take your time, and not to get bored easily, and just put yourself in a mental status that you will take time in this case more than other cases. So here there was a tear and an operculation, but as we can see that in the previously in the video, it was tightly adherent and was difficult, but as time goes by, more hydration, more force, it comes out more and more easily. Okay, now I'm going to shift to the cutter and remove the posterior alloy that I just detached. But still, there is this part, the temporal part, where there is pigmentation. I still couldn't go around it by any means. But I didn't shift to by manual. I'm not used to going by manual often, so I tried more
But you
and more.
succeeded to remove the anterior vitreous, and this is the most important part.
Yes.
So the
Okay.
other one, you can continue the surgery and the shaving of the vitreous while you are shifting on air. So if you are going to shift on air, not direct PFCL silicone exchange, and this may make the retina much more stable, and the gel can be easily removed from these peripheral areas of the retina.
I want to highlight here that even if there is no staining of the vitreous, but we can still know that the vitreous is there, because the PFC bubble is irregular. It's not taking the regular shape or the regular curvature. This means that there is still posterior hyaloid that needs to be addressed in this area. So I am injecting more and more PFCL as the bubble is becoming smaller by the suction of the cutter, and pulling on this area. What's the direction of your force? Do you pull just anteroposterior, or do you try to tease it out in different directions?
In different directions, and just to avoid any force that may induce any pinpoint or iatrogenic breaks from this hard pulling.
Yes. So I found, yes, this is very helpful, that you shouldn't just pull in one direction. You have to pull in different directions, not just anteroposteriorly. You have to pull in tangential manner. This helps to loosen the posterior hyaloid.
Yes.
There is one still area in the inferior part that there is an attached posterior hyaloid. And we will notice here that as I'm pulling, there will be a spot of hemorrhage from the pull. Again, you would continue and not stop, because this is
Yes.
if you stop here and leave this amount of vitreous, there's a higher risk of recurrence, right?
Yes,
Even
yes.
if hemorrhages happen or anything happens.
And also, what is very interesting, you're showing that you are alternating between the cutter and the forceps. So this may be very tedious procedure, that you, every time you take the cutter out and put the forceps in. So keep doing this, and this is in my opinion, is very safe to achieve the target you are doing, that you remove all the vitreous. Don't add the chandelier, because even if you add in, sometimes you cannot peel all these hyaloid with the bimanual, and you just need to alternate between cutting and doing this pulling. Other are showing us nowadays that they are using the chandelier and with one hand using the forceps and the other one using the cutter. So they are pulling and then they cut. So this is another way that you can deal with this peripheral vitreous, but I didn't do it so much.
Okay, so now I'm adding more PFC and then lasering the retina under PFCL. So would you do this or shift to air and then laser the retina?
No, I do the laser under the PFCL to have a better view, because
Okay,
sometimes if the lens is fogged with the uh, air bubbles coming from the PFCL exchange with the air, this may hinder your vision
okay.
and will not be pure for the periphery
Yes.
as you're showing us.
Yes, I that's the same reason I do this. I try to finish as much as possible when the visualization is good, and then I shift to air. Would you do direct PFCL exchange?
No,
Direct silicon PFCL? You don't do
no,
it.
no,
You don't do it in regularly. You
no.
mean? It's the same for me. I don't do it regularly. I shift to air and then aspirate the fluid.
But if you are going to do this step, you have to give a very, very good timing for meticulous removal of the fluid, and you keep suctioning the fluid at the edge of the GRT to avoid any slippage later on.
Okay. Another question. You can see here that there's the anterior edge of the brake,
Flap.
the anterior flap of the giant retinal tear. Would you remove it,
Yes, I removed.
or do you laser it like I'm doing here?
No, I removed.
Okay, so this is a controversial area. Some people, as you said, just remove it because it's considered like a nidus for proliferation and PVR. But here it was a bit large area for me to remove, and so I decided to just trim as much as possible and then laser what's left up to the retinal edge. How much of a slippage would you say that this is okay and then leave it? And if you find a large area of slippage, would you when do you where do you put your limits for
No,
the slip?
I'm not.
You
I cannot tolerate any level of slippage.
any level of
Yeah,
slippage.
no,
So here there is some area in the temporal area here that it slipped a little bit. Would you leave it this in? Would you leave this in place, or
no.
would you
I will keep
revise the
suctioning.
surgery?
No, I will keep suctioning using the fluid needle with passive aspiration, and I'm trying to massage this area to avoid any under-retinal fluid. Even if it is outside the macula and the possibility of retinal fold is very, very minimal, I don't like to leave this large area with lasered area with any area of abnormal attachment or irregular retinal architecture, because
Okay.
this may tend to induce more PVR or a membrane over this area and may pull over the whole lasered area.
Okay, so here there was a minimal slippage. I tried with the flute needle. I think I got most of it, but still, in my mind, I believe that there's some area that is not perfectly attached, and I just left it on silicone oil. Of course, you will use silicone oil in this
Yes,
case,
sure.
right?
Yes.
Okay, and how long would you keep it inside the eye in such young age?
3 to 6 months.
You don't like to prolong more than that in especially in pediatric cases.
It wouldn't differ because the laser already do its scoring in 14 days.
Okay,
So you just keep this longer period to avoid or to minimize any membranes or any proliferation, because these pediatric age group are more tendent to induce more inflammation and epiretinal membranes. So that the presence of silicone may help you to avoid any later on tractional retinal detachment or recurrences if you remove the silicone earlier. But just to secure or to guard against the opening of that tear, this is already secured after 1 month.
okay.
You didn't add any buckle or bands
No,
to this
no,
search.
I didn't add. No. I tend to add buckles if there's an inferior GRT, but I still don't believe it makes a lot of difference, especially in giant retinal tears, because if you trim the edge more and more posterior, I believe that the silicone doesn't do can tamponade it easily without the use of a bucket.
Yes, there was a systematic review in the caution library comparing whether to add a band to GRT groups of patients, whether pediatric or adult, and without just doing vitrectomy. And the conclusion was there is no need or there is no added value for the band for these cases.
Okay. Okay. Thank you very much for watching.
Thank
Stay
you.
tuned to the next one. Thank you.
Thank you.